Hello everyone. Today we will be talking about Generation PMTO, formerly known as Parent Management Training Oregon Model. This presentation is designed for MSW students and clinicians to gain an understanding of the Generation PMTO treatment modality. In this presentation, we will go over the history of Generation PMTO, an overview of the goals and outcomes, key components, the populations which it serves, and the settings where this modality is frequently used. We will then explain what the implementation of PMTO looks like in practice, share the effectiveness and outcomes, explain the costs associated with training and therapy services, and then describe the limitations to consider when practicing Generation PMTO. Generation PMTO is a treatment model which has been developed over the last 50 years at the Oregon Social Learning Center. The purpose of this model is to provide interventions for families with youth experiencing conduct-associated problems, including aggression, antisocial behaviors, defiance, delinquency, and substance use. It was created by Gerald R. Patterson, who's a research scientist and the founder of the Oregon Social Learning Center. The model was actually first implemented nationwide in Norway in 1999, but has since established programs in Iceland, the Netherlands, Denmark, Uganda, Kansas, Minnesota, British Columbia, New York City, and Michigan. More specifically, programs have been established in Wayne County. The main goal of Generation PMTO is to work with parents to increase positive parental involvement and reduce coercive family practices. This involves helping parents examine the antecedents to their child's problem behavior and work to shift those antecedents as well as the consequences which follow the child's behavior. It is based on the social interaction learning theory, which emphasizes the impact of one's environment on their behavior. It also assumes that adverse consequences that may be present in a family's individual context can make it difficult to parent, thus increasing the likelihood that parents will become coercive. The outcome goals for Generation PMTO are to reduce problem behaviors, improve academic performance, and increase overall social competency in youth. In order to do this, therapy sessions focus on 5 key components. These components include encouraging positive behavior on behalf of the parents, using family problem solving to prevent conflict and manage family stress, positive parental involvement, limit setting to decrease what are deemed as problem behaviors, and monitoring and supervision to ensure that both parent and child behavior stays on track.
Who is Generation PMTO geared towards? One of the unique features of Generation PMTO is that it mainly focuses on working with parents. In particular, it's working with parents whose children are exhibiting defiant, disruptive, and other problem behaviors. This could be anything from fighting, lying, stealing, arguing, getting in trouble at school, among many other behaviors. Generation PMTO is meant for children between the ages of 2 to 18. Generally, these youth would have a diagnosis of conduct disorder, oppositional defiant disorder, or other antisocial behaviors. Not only can Generation PMTO be used by biological parents, but it's been successfully used by step-parents and single-parent households who have experienced a divorce. In addition, evidence shows that foster parents can utilize Generation PMTO with children staying in the home with them. Finally, Generation PMTO has been adapted to be used in a group setting with parents whose children have been removed from the home. This group is called Parenting Through Change Reunification. This allows parents to gain parenting skills in order to reunite with their child who has entered into the foster care system. This group goes for about 10 weeks and allows parents that are in a similar situation to learn together and provide social support as well. Where is Generation PMTO utilized? PMTO therapy is very versatile and can be done in a variety of settings. In Michigan, Generation PMTO is mainly utilized in the community mental health setting. However, it can be effectively used in any outpatient clinic. Generation PMTO can also be adapted as a home-based treatment, working either in the birth home, adoptive home, or foster home. In some ways, conducting Generation PMTO in the home may be more effective because it gives the therapist more insight into the home environment and what may be leading to the child's problem behaviors. As previously mentioned, Generation PMTO has been adapted into a group therapy which can be utilized in a variety of community settings. These could include community centers, schools, or homeless shelters. Finally, Generation PMTO can be utilized over the phone, which is a key component of this therapeutic intervention. So what does a Generation PMTO session look like? Generally, parents would meet with their therapist one time per week for an hour. These sessions are usually done one-on-one between the parent and the therapist. However, sometimes the child can be incorporated as well. Parents will be engaged in treatment from anywhere between 3 to 6 months, depending on the severity of their child's behaviors. This equates to 10 to 25 sessions. However, in milder cases, results can be seen in only 6 to 8 sessions. In session, therapists will work to teach parents different skills in order to help them shape their child's behaviors. In order to do this, the therapist will utilize role plays heavily to allow parents to practice the skills that the therapist is teaching them. This means that the therapist would play the role of the child and allow the parent to put the skills they're learning into practice. After practicing in session, the therapist would then give the parent a homework assignment to try the skills at home with their own child. Parents can follow up later in the week to troubleshoot any problems that they encounter when doing their homework assignment over the phone.
When we look at the homework attached to Generation PMTO, we find that it's designed to examine the behaviors of parents by looking at antecedents, behaviors, and consequences. These are the ABCs of PMTO. One example of a homework problem might be something like the Family Problems Inventory, where parents will be instructed to, at some point in the coming week, look at some questions around their family health problems, their marital problems, financial problems, or behavioral problems with other children in the family, and create a 2-column inventory examining problem areas and proposed solutions. This homework will then be brought back to a therapist who functions much more like a coach or a teacher, where the therapist, the Generation PMTO clinician, will examine the homework, critique it, and then the parent will role play. The role plays practice both explaining the reasoning for techniques and implementation of the strategy. So a homework review or a session will both look at how do we explain this to the child, the reasoning behind a intervention that's about to be utilized, and how are you going to, as a parent, actually play this out. If we take a little bit of a closer look at the ABCs, we'll see that the treatment, it can be framed in one of 2 ways, either anticipation or consequences. So when there is a problem behavior from a child, the behaviors that we're looking to correct, we can either anticipate beforehand what the behavior will look like and come up with some sort of strategy for it, such as putting locks on doors to create child-proofing of cabinets so kids aren't getting into the cabinets and stealing the cookies and throwing them all over the floor, or by creating consequence systems such as a token economy. Imagine this being something like Harry Potter points, where there are plus points and minus points. For young children, it's advised that we use physical chips in some cases, something like poker chips, so that a child can see their accumulated actions growing in something like a bank, like it could just be a shoebox, or even watch those chips be taken away. If we look at the effectiveness and outcomes of Generation TMO, we'll find it is very well researched and proven effective in a number of different settings around the world. There is strong evidence that the treatment works across a variety of different groups. We've chosen 4 particular groups to highlight here, those being biological families, foster care situations, particularly foster care youth who are trying to reunite with their biological family of origin, and divorced families. And the divorced families will be looked at both with single-parent homes of the sons of divorced mothers or families that have a step-parent. So if we begin with biological families, the first study was conducted at the Oregon Social Learning Center where the Generation PMTO began. In a randomized controlled trial, 19 families with 3 to 12-year-old children were assigned either to the PMTO experimental group or to a comparison group where the comparison group just received regular services. And this will be a theme throughout all of the studies. Regular services can be comprised of anything from behavior modification to an Adlerian approach to structural family systems therapy to a mixed modality of many of these. In the first study conducted at the Oregon Social Learning Center, the PMTO group showed a 63% reduction in the mean rate of behaviors from the baseline level. And 90% of parents in the experimental PMTO group reported the treatment was very effective. This is juxtaposed to only 25% of the families in the control group reporting their regular services as being very effective. Equally encouraging is a report from Norway, where PMTO has been adopted and nationalized and is now the primary treatment for deviant behavior in children. Again, families were randomly assigned to either a PMTO experimental group or to a control group of regular services. Results showed that the PMTO was effective in reducing parent-reported child externalizing problems, improving teacher-reported social competence, and enhancing parental discipline. To break those things down, when we talk about externalizing behavior, we are referring to a grouping of behavior problems that are manifested in children's outward behavior and reflect the child negatively acting on the external environment. The teacher-reported social competence was measured using the SSRS scale, or the Social Skills Rating System, and parental discipline was self-reported. In the foster care setting, we can examine where PMTO has been effective in populations that are historically considered much more difficult to work with. During a 2-year study in Kansas, research conducted on foster youth investigating social-emotional well-being found small but significant positive effects on social-emotional functioning, problem behaviors, and pro-social skills. When we are looking at particularly foster care youth in America, these studies tend to focus on how well socialized a child is. And these pro-social skills tend to reflect the rates of contact with deviant peers being peers who are also engaging in antisocial behaviors. So with the Kansas study, we find that 6 months after baseline, an analysis of covariance model examined the intervention's overall effect and time interactions using intent-to-treat analysis. Foster care case managers assessed children who had received PMTO to have increased their social-emotional functioning, and parents who received PMTO reported improvements in the children's problem behaviors and pro-social skills. Further research examined the effectiveness of PMTO for foster parents with foster children, with severe externalizing behavior problems in long-term foster care arrangements. A significant effect of PMTO compared to care as usual, again, the PMTO experimental group versus the regular services group, was expected on reduced parenting stress and improved parenting practices. The Oregon divorce study, conducted across around the year 2002 to 2011, used a series of assessments ranging at 6-month intervals from the first 6 months up to 9 years of follow-up. The research has demonstrated PMTO's effectiveness with families who are divorced or who have a step-parent. Specific relationships examined were those of children in homes with a stepfather and the sons of divorced mothers. Analysis of the 9-year follow-up data indicate that the Oregon model of parental management training significantly reduced teacher-reported delinquency and police arrest for focal boys. Furthermore, reported association with deviant adolescents or deviant children was reported to decrease, leading to fewer arrests, fewer suspensions, and fewer teacher interactions that were reported as negative.
Mm-hmm. So if any of you MSW candidates out there were curious about how to get trained in Generation PMTO, that information is right here for you. So getting trained in this specific treatment is somewhat extensive, and that's part of the reason that there aren't very many therapists trained in this. So individuals need to complete 5 different workshops and coaching seminars, and these take place over 18 different workshop days. These trainings are extremely extensive and helpful. They consist of videos, role plays, and demonstrations among a lot of other interactive and engaging activities. At these trainings, individuals will also receive materials such as a manual for practitioners with a lot of history, tips and tricks and ideas on what to do when carrying out this treatment, as well as a handbook to give to parents so they know what to expect and to be able to answer any questions they might have. This training and certification process is also extremely observation-based. So while participants are meeting with families and administering services, they film these sessions. They then submit these sessions to supervisors and coaches. This training process also involves coaching and supervision, as I just mentioned. So all trainees must meet or Skype or have phone calls with a coach at least 12 times for consultation and support. These coaches will have watched the videos that they had submitted and be able to give some notes and feedback. And the participants will also be able to ask questions or troubleshoot some things that they've been dealing with. General training. That's not even into the certification candidacy part of the training. So 3 main things that they mention in order to move on to certification candidacy are: you must provide services to at least 3 families. You must effectively incorporate feedback from your coach, and you must demonstrate competency in carrying out the intervention. So after having done all of that, then you will move on to certification candidacy. And in order to gain full certification, the candidate must provide services to, and again, to record and upload these sessions. And these are 4 specific sessions. They are introducing encouragement, troubleshooting encouragement, introducing discipline, and troubleshooting discipline. These sessions are then scored using the FIMP rating scale. In order to pass and gain full certification, the mean score for each session must be a 6 or higher, and none of the scores can be under 4. Upon certification, individuals are encouraged to become coaches so that they can guide and support others in their training and supervision. So in order to be trained, one must be a master's level clinician or be a bachelor's level clinician with at least 5 years of experience. They also must meet Medicaid credentials and requirements for skill training and intervention. And lastly, they must be able to successfully provide mental health services to children and their families. So here I have the cost of implementation. When we were looking into the cost and availability of Generation PMTO, we noticed that it is very expensive for a center to implement. However, once the initial year 1 cost is paid, there's not really any additional cost for materials and curricula beyond phase 1. So a lot of different articles and websites said that it really was a very positive investment. So even though it's a lot of money at the beginning, you won't be paying much after, and the benefits that you'll get from the very extensive training, they'll outweigh the costs, many people have said. So the cost for year 1 of implementation with a team of 16 clinicians is as follows. So the training, coaching, technical assistance, and curricula is $515,000. And then you must pay for staff time. This exact number is based on a part-time staff of 16 clinicians, which is generally how this is staffed, and that would be $40,000 for staff time. And then there's fringe at 30%, and this is related to the fringe benefits that the staff members receive, and that would be $120,000. And then you must pay for the travel of the ISII team. This stands for Implementation Sciences International Incorporated, and these are the people that come in to begin the trainings and really get people excited and train the individuals that will then be training your participants. That costs $1,000 per trips, and they have 5 trips, so $5,000. Lastly, you have the overhead cost and administrative staff cost, which is $130,000. So that all adds up to the total year 1 cost of $1,170,000.
In 2017, the full program cost for families to participate in Generation PMTO was $1,089 to $1,643 per family. The service is billed as mental health therapy for individuals, families, or groups, and Medicaid can be a major source of support for costs if families are eligible. Other sources of funding support for families include child welfare agencies, juvenile justice programs, and community mental health service grants.
So what are the limitations of Generation PMTO? As we mentioned, there's a high cost to organizations, which makes it difficult to implement. In addition, it takes clinicians a long time in order to become certified in Generation PMTO. This means that clinicians would need the support of their organizations to allow them to take the necessary days off site to complete trainings and potentially pay for these training sessions. This may contribute to the fact that there's a limited number of clinicians certified in Generation PMTO, which means this intervention is not available to everyone that might need it. Another limitation of Generation PMTO is that it's dependent on parents' ability to change and learn from therapy sessions. Generation PMTO doesn't take into account the parent's own mental health issues or generational trauma that might contribute to a parent being unable to effectively participate in the intervention. Even if parents can effectively participate, it also requires that parents be engaged and available. If parents are not motivated or engaged in session, this intervention will not be effective. So in some ways, it puts a high burden on parents who might already be very stressed and have a lot of demands on their time. In addition, parents' expectations can sometimes make this intervention difficult. When a parent comes into treatment due to their child's behaviors, they may be expecting therapy service for their child and be caught off guard when the therapist wants to work one-on-one with them. Some parents may take offense to the idea that their parenting is what led their child to behave poorly and therefore be less likely to complete the intervention. Generation PMTO tends to be more effective in younger children and can be less effective in older and more aggressive youth. This means that it's important for children to receive treatment as early as possible. However, with the limited number of clinicians available to conduct this therapy, they may not be able to receive necessary services. Finally, as mentioned before, PMTO is not widely practiced across the United States. Right now, Generation PMTO is practiced in Michigan, New York, Missouri, Minnesota, Kansas, Oregon, and Utah. This means that there are many places across the country where children and parents can't receive this well-supportive and effective treatment. Thanks so much for listening to our presentation on Generation PMTO.